In this video, I will go over the platelet, coagulation, and hypercoagulation disorders. But before doing that, I would first like to go over the mechanism of primary and secondary hemostasis, after which it would be so easy to explain every one of these disorders. So first, let's go over the mechanism of primary hemostasis. So if this is a blood vessels, and once there is an injury in part of it, it will cause exposure of the collagen, and to the collagen there is one Willebrand factor that is bound to it. And then the GP1B receptor of the platelets will be able to bind to the von Willebrand factor, and after this binding it will cause release of the granules, which will contain the thromboxane A2 and ADP. And ADP will act on the ADP receptors, so this is an ADP receptors, and once ADP binds to it, it causes configuration change of the platelet, as a consequence of which the other receptor that is called GP2B3A will be able to be exposed to the cell surface, and GP2B3A will be able to bind to the fibrinogen. And thus, via this mechanism, there would be other platelets that would be able to bind to this single platelet. So all the platelets will be joined together via binding of the GP2B to the fibrinogen. So here we will have another platelet right here, and then another platelet. So platelets will come together via this mechanism. And this is referred to as primary hemostasis. So here is a summary of the findings. So once there is a damage to the collagen, von Willebrand factor will bind to the collagen, and then from there on, GP1B receptor will bind to the von Willebrand factor. Granules will be released, which contain the ADP. ADP acts on the ADP receptors, cause conformational change that will lead to the exposure of GP2B3A to the cell surface. And then all the GP2B3A of platelets would be able to bind together via the fibrinogen being placed in between. And this whole mechanism is referred to as primary hemostasis. Now, if there is a patient that have deficiency of the von Willebrand factor, in addition to functioning here in the formation of platelet plug, it also carries the factor 8 coagulation. So if there is deficiency of the von Willebrand factor, therefore there would be increased bleeding time in these patients, and since there is deficiency of factor 8, there would be also increased PTT. And I will explain PTT in a second with you. Now, the treatment for patients with von Willebrand deficiency is that you will have to give them desmopressin. And this desmopressin, what it does is that it induces the release of the von Willebrand factor from Weibel-Palade bodies of the endothelial cells. Then there is this other condition called Bernard-Solier disease, and this is due to the deficiency of GP1B. There is this other condition called Glanzmann thrombasthenia, and this is due to the deficiency of GP2B3A, and both Glanzmann and Bernard-Solier are associated with increased bleeding time due to the problem with the primary hemostasis. Then we have this other condition called idiopathic thrombocytopenic purpura, and this is due to the formation of the IgG antibodies against the platelet surface as well as the GP2B and 3A, and these patients again present with the petechia and bleeding. And then we have thrombotic thrombocytopenic purpura, which is due to the deficiency of ADAM-TS13, which is required for the breakdown of the von Willebrand factor. So if there is deficiency of the ADAM-TS13, then there would be increased von Willebrand factor multimers, as a consequence of which there would be increased platelet aggregation, and thus there would be increased thrombosis and schistocyte formation. So for both of these conditions, ITP and TTP, due to the reduction in the number of platelets, there is an increased bleeding time. Now, one other point I would like you to know is that there is a condition called hemolytic uremic syndrome, and this condition has similar presentations to TTP, but the main difference is that hemolytic uremic syndrome is generally associated with the consumption of raw hamburger due to the presence of the E. coli O157H7. And then the final condition that we have here is called disseminated intravascular coagulation, where there is a widespread clotting. For instance, in patients that are pregnant, Trophoblast contains the tissue factor, which can lead to widespread clotting. In addition, patients that have malignancy, will release the procoagulant factors that again cause widespread clotting. And then patients with the G-negative bacteria sepsis, since they have the lipopolysaccharide that contains the lipid A, and this whole component is called endotoxin, again, it can cause the coagulation. Finally, trauma, pancreatitis, and transfusion reactions, again, all of these conditions can cause DIC. And then due to the increased use of the platelets as well as the coagulation factors, these patients present with increased bleeding time, increased PTT, increased PT, and then finally increased fibrin split products. And then there is also formation of schistocytes or helmet cells, where the red blood cells is damaged and has an appearance something like this, schistocyte or helmet cells. Now, speaking of schistocyte, I would like you to know that there are 3 conditions that you will have to know for your USMLE exam that are associated with the formation of schistocytes. So schistocytes or helmet cells, so red blood cells will have like kind of a helmet-shaped appearance, and this is due to the damage that is made to the red blood cells. It's associated with TTP and disseminated intravascular coagulation. So since there's too much clots that are formed while the red blood cells are passing through the vessels, they keep hitting these clots and then they would be damaged, forming the schistocytes. And then finally, patients that have prosthetic heart valves, these valves are too harsh for the red blood cells, and then again it can cause damage to them and their shape will start to change. So just keep that in mind. TTP, DIC, and prosthetic heart valves are associated with the formation of the schistocytes. So these disorders were all associated with the primary hemostasis. Now I mentioned that there is also secondary hemostasis, and this is through the coagulation cascade, and the whole purpose of the secondary hemostasis is to cause formation of a fibrin mesh which will stabilize the platelet clot that has been formed earlier. So there are 2 different pathways that can lead to the activation of the thrombin and the formation of fibrin. It's called the intrinsic, which acts via the factor 12, 11, 9, and 8, and then the extrinsic pathway, which acts via the factor 7. And so with the extrinsic pathway, what happens is that once there is a tissue injury, there would be exposure to the tissue factor, which will activate factor 7 and leads to the activation of the common pathway. Now, you can monitor the activity of the extrinsic pathway via the PT, also known as prothrombin time. And then you can monitor the activity of the intrinsic pathway via PTT, which stands for the partial thromboplastin time. And then the mnemonic that you can use is that for intrinsic, think of PIT, while for extrinsic, think of PET. So extrinsic pathway, you can monitor that by PT, while intrinsic pathway, you can monitor that by PTT. In any case, once these cascades are activated, it will lead to the activation of the thrombin, which is factor 2, and then thrombin will cause conversion of factor 1 or fibrinogen into fibrin. And then thrombin itself will also act on factor 13, and factor 13 will cause the formation of fibrin polymers. So here we had the fibrin monomer that has been formed by thrombin, and then factor 13 will be activated by thrombin, and that would cause conversion of the fibrin monomer into the fibrin polymers or fibrin mesh. And this will stabilize the platelet clot that has been formed. Now, just like many other pathways that are present in our body, this pathway also has a negative feedback, and the way it works is that thrombin will bind to the thrombomodulin, which is present on the endothelial surfaces, and then the thrombomodulin will activate protein C, which via its cofactor protein S would be able to block the function of factor 5 and factor 8. So patients that lack protein C and S will have hypercoagulation because there is too much activity of factor 8 and factor 5. And then also mutations in factor 5 will cause factor 5 insensitive to protein C. So protein C will no longer break down factor 5 in these patients, and again that would be another cause of hypercoagulation. In any case, now that we've covered both the primary and secondary hemostasis, it's now easy to go over the platelet, coagulation, and hypercoagulation disorders. So the first disorder is thrombocytopenia. thrombocytopenia. So generally we have about 150,000 to 400,000 platelets in the body. So if there is less than 150,000, then that is referred to as thrombocytopenia. And if there is less than 50,000 platelets, then there could be spontaneous bleeding in these patients. So common causes of thrombocytopenia include the bone marrow failure, such as aplastic anemia or fibrosis of the bone marrow, or there could be destruction of platelets, for instance, from ITP, from TTP, or there could be sequestration. For instance, in a patient that had splenomegaly, platelets can remain inside the spleen, and thus there would be thrombocytopenia because of sequestration. And then finally, there could be dilution effect. In individuals who are receiving too much transfusion, then there would be too little platelets, and thus there would be bleeding and petechia. So symptoms of patients with thrombocytopenia include petechia and purpura. The next condition is idiopathic thrombocytopenic purpura, which I've discussed it earlier with you, and these patients are associated with the formation of IgG antibodies against the platelet surfaces, as well as the platelet GP2B and 3A, as well as sometimes GP1B, as a consequence of which these platelets will be removed by macrophages, and thus there would be increased bleeding time in these patients. And then patients with thrombotic thrombocytopenic purpura, which is due to the deficiency of ADAMTS13, which is a von Willebrand factor metalloprotease, since there is increased levels of the von Willebrand factor multimers, will develop increased platelet aggregation and thrombosis, as well as the formation of the schistocytes. And the presentation of the TTP include craft. So these patients present with CNS symptoms, renal symptoms, anemia, fever, and thrombocytopenia. Now you may have noticed that TTP is sometimes called TTP-HUS. So both HUS and TTP are presenting with the same symptoms, and their treatment is the same, which you will have to provide them with a plasmapheresis. But then the cause of the TTP and hemolytic uremic syndrome is different. So TTP, as I just discussed, is caused by the deficiency of the ADAMTS13, while HUS is caused by the E. coli 0157H7, and then HUS is more associated with renal symptoms, while TTP is more associated with the CNS symptoms. But the presentation of and the treatment of both conditions is the same, as a consequence of which they are both usually referred with the same term called TTP-HUS. The next condition is the Bernard-Soulier syndrome, which is due to the deficiency in the GP1B, as a consequence of which there would be decreased platelet count in these patients, and thus there would be increased bleeding time. And then finally we have the Glanzmann thrombasthenia, where there is defect in the GP2B3A receptors. In these patients, however, the plate count is normal, but then there would be still increased bleeding time because of the defect in these receptors. Then next I would like to discuss the coagulation disorders, and the first disorder is the von Willebrand disease, which I discussed with you earlier. So this is the most common cause of bleeding, and this is an autosomal dominant disorder. So if they ask you which one is more common, which of these bleeding disorder, von Willebrand disease or hemophilia, the answer is von Willebrand disease. And von Willebrand disease is due to the deficiency of the von Willebrand factor, so therefore there would be increased bleeding time in these patients. And von Willebrand factor is also responsible for carrying factor 8. So since there is also deficiency of factor 8 in these patients, therefore there would also be increased PTT in these patients. And then you can use the ristocetin induced platelet aggregation to detect the von Willebrand disease. Now the treatment for von Willebrand disease is desmopressin, and what it does is that it induces the releases of the von Willebrand factor from the Weibel-Palade bodies of the endothelial cells. The next condition is hemophilia, and there are two forms of hemophilia, both of which are X-linked recessive, and there is hemophilia A, which is caused by the deficiency of factor 8, and then hemophilia B, which is caused by the deficiency of factor 9. So the way you can memorize it is that factor A sounds like 8. So factor A is due to deficiency in factor 8. And then these patients present with hemophilia arthrosis, where there is particularly bleeding inside the knees. And then there would be increased risk of intracranial bleeds from head trauma. And then due to the deficiency of these factors, lab findings show increased PTT in these patients. The next condition is disseminated intravascular coagulation, which I just explained can be caused by different causes, such as pregnancy, where there is trophoblasts that express the tissue factor. It can be caused by malignancy, where there are procoagulant factors, or gram-negative sepsis, where the lipid A component of the lipid polysaccharide acts as an endotoxin and causes the widespread coagulation. Trauma, pancreatitis, and transfusion reaction, as well as rattlesnake venom, are other causes of disseminated intravascular coagulation. So these patients generally, because of the use up of all the platelets and the coagulation factor, have low platelets, they have low fibrin, and since fibrin has been used up and been broken down, there is increased fibrin split products. Since all the coagulation factors are used, there is also increased PT and increased PTT, and then there is increased D-dimer that is formed in these patients. And then the general presentations of patients with DIC include the ecchymosis, petechia, and purpura. And then I mentioned earlier that transfusion reaction can cause DIC. So if you actually start transfusing a patient and they develop DIC, you will notice that there is actually oozing of blood from the transfusion site. Because all the platelet factors and coagulation factors are used, this patient will start bleeding. Now for the treatment of the DIC, you can use the fresh frozen plasma, which will replace all the clotting factors. You can also give these patients platelets, or you can also give them cryoprecipitate, which contains the fibrinogen, factor 8, factor 13, and the 1 Willebrand factor. So patients with DIC can be treated with fresh frozen plasma, which contains all the coagulation factor. You can give them platelet, and then you can also give them the cryoprecipitate. Decreased vitamin K is also another cause of bleeding, and the reason for that is that vitamin K is required for the post-translational modification of the coagulation factor 2, 7, 9, and 10. And it's also required for the modifications of protein C and S. So just be careful that vitamin K deficiency can cause increased risk of bleeding because of the deficiency of these factors. Now, children and patients that are taking antibiotics for a long term are at increased risk of developing vitamin K deficiency. And the reason for that is that vitamin K is being made by the normal flora of the GI tract. So if a patient is taking antibiotics for too long, then there would be destruction of normal flora of the GI tract, as a consequence of which there would be vitamin K deficiency. Likewise, newborn children will have vitamin K deficiency because their GI flora may not be already well developed to help them with the vitamin K. That's why newborn children are receiving a shot of vitamin K. Now, warfarin is an anticoagulation medication that has a similar structure to vitamin K, and it functions by blocking the effects of vitamin K, and thus there would be decreased carboxylation of factor 2, 7, 9, and 10. But then when you give warfarin to cause the blood thinning in these patients, since proteins C and S are also affected, and these proteins have anticoagulation properties by blocking factors 8 and factor 5. So since the half-life of protein C and S are shorter than factors 2, 7, 9, and 10, patients that are taking warfarin will initially there would be increased risk of thrombosis. Now, the next cause of the coagulation disorder is the liver failure. So it's the liver that is producing all the coagulation factors with exception of the von Willebrand factor. So therefore, in patients with severe liver disease, they can develop coagulopathy, as a consequence of which usually they present with the GI bleed, secondary to the varices that develop because of the portal hypertension. And then finally, we have the hypercoagulation disorders, which I've already discussed some of them with you. So factor 5 latent, since there is a mutation in factor 5, this factor 5 would not be inactivated by the protein C and S, and thus there would be hypercoagulation. Antithrombin 3, so inhibitor of thrombin 3 is absent in these patients, as a consequence of which there would be too much thrombin, and thus again there would be hypercoagulation. Protein C and S, I discussed that they would inhibit factor 5 and factor 8, so if there is deficiency of either one of those, then there would be again hypercoagulation. And then 2210 mutation in the prothrombin gene will cause increased risk of clot formation. As for antiphospholipid antibody syndrome, this is secondary to the lupus, or SLE, and these patients will develop hypercoagulation, and thus there is increased risk of the pregnancy abortion because of the hypercoagulation in these patients. And that concludes our discussion.